Добрый день.
Dear colleagues and guests, today is the 28th of September 2021, 15:00 Moscow time. I am announcing a technical break for 5 to 10 minutes.
Технический перерыв номер 1.
The technical break number 1 is over. Please let me continue the dissertation committee meeting of dedicated to the defense of the dissertation of Ermakova, Nataliya, Georgievna, seeking academic degree of Doctor of Psychological Sciences in the degree field 1904, Medical Psychology, on the topic psychological rehabilitation of patients with the consequences of a stroke in a rehabilitation hospital. Let me start this, let me continue this meeting by the act of Academic Secretary, St. Petersburg University, Alexander Valentinovich Gnetov, dated on the 3rd of June 2021. I, Valentina Mikhailovna Bызова, Doctor of Psychological Sciences, Professor of the Department of General Psychology, St. Petersburg University, was appointed chairperson of this dissertation committee. Also on the committee serve the following members: Valentina Anatolyevna Babkov, Doctor of Medical Sciences, Professor of the Department of Medical Psychology and Psychophysiology, St. Petersburg University; Svetlana Timofeyevna Poskhova, Doctor of Psychological Science, Professor of the Psychology of Education and Pedagogy, St. Petersburg University; Yelena Rudolfovna Isaeva, Doctor of Psychological Sciences, Professor of the Department of General and Clinical Psychology, the first St. Petersburg State Medical University named after Ivan Pavlov. Also in a remote mode with us are Tatiana Arturovna Karavaeva, Doctor of Medical Sciences, Associate Professor and Senior Fellow of the National Medical Research Center of Psychiatry and Neurology, named after Bekhterev. Can you hear and see us? Yes, the answers are positive. Konstantin Viktorovich Karpinsky, Doctor of Psychological Sciences, Professor, Head of the Department of Experimental and Applied Psychology of Grodno State University, named after Yanka Kupala, Belarus. Can you see and hear us? Yes, I can. Also with us, the candidate is the candidate Nataliya Georgievna Ermakova. To improve the quality of communication, please, dear colleagues who are in a distance mode with us, turn on your microphones when you're not speaking, and when you're given the floor, don't forget to turn them off. Also, I would like to say that a video and audio recording accompanied by simultaneous interpretation between Russian and English is carried out on the website of St. Petersburg University. Also, on that screen, you will see an email address where you can send your messages concerning the discussion and the dissertation. These questions will be relayed to me by technical services in order for me to read them. The questions should have immediate relation to the presentation of the candidate and the content of the station. Well, the questions should be accompanied by should be signed and with the affiliation of the author. No questions that have no relation to the academic discussion or the discussion of the dissertation will be read. nor will be read anonymous questions. In accordance with the Act of Awarding Academic Degrees at St. Petersburg University, academic degrees of a candidate of sciences and doctor of sciences, a session of a dissertation committee is legitimate when not less than 2/3 of the established membership of the dissertation committee, but not fewer than 4 people, are present. Our committee consists of 6 people. All 6 people are present, including 2 members of the committee in an interactive remote regime, remote mode. Please, I would like the member of the dissertation committee support office prepare a registration list, registration register or logbook, and would like to inform you that today's committee session will last for about 2 hours, approximately 2 hours. It will consist of the following: a short presentation by the chairperson of the committee about the candidate and the paperwork that has been submitted by the candidate. Any questions to possible answer any questions will be asked and answered. 5 minutes. Short presentation of the candidate seeking the academic degree that covers key issues in the dissertation. 20 minutes. Questions to the speaker on the presentation, not more than 2 minutes per question. Answers from the candidate, not more than 5 minutes for all questions. And all members of the dissertation committee will have in turn the opportunity to present their assessment of the dissertation. 10 minutes per speaker. Then the chairperson will have the same opportunity, 10 minutes. The candidate will have 20 minutes to answer questions and critical remarks from the committee members, and then open floor discussion. In order to speak, you have to register in the logbook for the and when you ask a question or make a comment, always introduce yourself. And then the chairperson will read questions that had been submitted through email to the committee, but no questions that will take longer than two minutes to read will be voiced. Then the answers of the candidate, not more than 2 minutes per question. Then and discussion or deliberation between the members of the dissertation committee before an open roll call vote, and broadcast can be switched off for these 5 minutes. Then open roll call vote, and then counting votes, and decision will be taken, and the concluding statement from the candidate. And now I'd like to start with the first item. Before I do that, please turn off your mobile phones, but those who are present in this room and those who are online with us, please don't turn off your phones for emergency communication. And I would like to make my short presentation of the dissertation and the paperwork, of the author of the dissertation and paperwork submitted by her. And the dissertation of Nataliya Georgievna Ermakova, seeking an academic degree of Doctor of Psychological Sciences in the degree field 190004, Medical Psychology, on the topic psychological rehabilitation of patients with the consequences of a stroke in a rehabilitation hospital. Was accepted for defense by the act of the academic secretary of St. Petersburg University on the 14th of May 2021. Nataliya Georgievna wrote her dissertation in the Russian State Pedagogical University named after Alexander Herzen. The number of publications that cover key findings include 21 works. 17 publications are in the journals approved by the Minister of Science of the Russian Federation, Education and Science, and Web of Science and Scopus publications, 3, and 1 book. All the paperwork, according to my knowledge, have been submitted in due course and in due time, and their copies are in the personal file available for consultation. Before I give the floor to the candidate, I have a question for the members of the Dissertation Committee. Do you have any general questions to the applicant, including if we need to go down the whole list of documents submitted? No. Then, Nataliya Georgievna, you have the floor for your presentation. Dear Chairperson of the Dissertation Committee, dear members of the Dissertation Committee, dear guests, in recent decades there has been an increase in the number of cerebral vascular diseases of the brain. In Russia, the number of strokes per year is 450,000, which is significantly higher than in the European Union and the United States. High morbidity is noted not only in old age and senile age, but also among people of working age. There's also a significant rejuvenation of the stroke. These circumstances make the medical and social problem of rehabilitation of post-stroke patients urgent, aimed at restoring impaired in function social contacts, returning the patient to society, and to work that they can do. Prevention, treatment, and rehabilitation of post-stroke conditions is a complex general biological and psychosocial problem, the solution of which requires a psychosocial approach. Organic lesions of the nervous system lead to severe functional defects, which are accompanied by motor and cognitive impairments and cause social and psychological maladjustment of post-stroke patients. In this regard, it becomes necessary to include a wide range of psychological assistance measures in the rehabilitation process. The degree of elaboration of the problem, it should be noted that at present, theoretical and methodological approaches and methods of biological and physical rehabilitation of post-stroke patients have been significantly developed. At the same time, psychological aspects of rehabilitation have not been fully studied and widely, which makes it relevant to carry out theoretical and empirical research in order to create a concept and model of psychological rehabilitation. And the development of comprehensive programs, psychological assistance to the patient and the micro-society, which is an important task for medical practice and medical psychology. Object of study: psychological characteristics of patients with the consequence of a stroke in conditions. Psychological rehabilitation of patients with the consequence of a stroke in the context of rehabilitation treatment. Research hypothesis. General hypothesis: a theoretical analysis of the literature on rehabilitation problems and an empirical study of the state of higher mental functions and psychological characteristics of the patient's personality at each stage of psychological rehabilitation contributes to the identification of psychological problems, of adaptation, and the creation of a concept and model of psychological rehabilitation. Personality oriented programs and psychological assistance aimed at optimizing the rehabilitation process. Purpose of the study: creation of the concept and model of psychological rehabilitations. On the basis of the research objectives, on the basis of a theoretical study of the state of modern problems of rehabilitation of patients after stroke, to identify the factors influencing a success of rehabilitation problems. Theoretical and methodological foundation of the study, and the psychosocial concept of mental disorders designated by Bechter have received terminological designs in the work of Angel. Organization of the study: the study was carried out in 4 stages from 1991 to 2014. The main sample consists of patients with a consequence of a stroke, 1,042 who received treatment in the conditions of rehabilitation in hospital in St. Petersburg City Hospital number 40. They participated in all stages of the empirical study. Patients with the consequence of stroke, 115 people who were on the outpatient observation of the outpatient clinic in St. Petersburg State Polyclinic number 114 of the Primorsky district of St. Petersburg, and underwent rehabilitation with the participation of a multidisciplinary team who also took part in the testing of the model. The number of men is 63, 52 women aged 38 to 94 with the different conditions. Ischemic stroke, 103 patients were observed. Hemorrhagic stroke, 12, with the disease duration from 2 weeks to 6 months. Primary stroke was observed in 73 patients, repeated in 43. Speech disorders were observed in 77 patients. Aphasia, 38. Dysarthria, 39. Severe movement disorders were observed in 28 patients, 5 points on the Rankin scale, and in 37 patients of moderate severity, 4 points, and in 54 patients mild movement disorders, 3 points on the Rankin scale. The analysis, attention was studied, the quality of life was studied, attitude to illness and treatment. Attention was studied, memory, thinking. Method was used MMC, short test for assessing cognitive functions. In the study of personality traits, the following was used: Minnesota Multidisciplinary Personality Questionnaires, MMPI. Provisions for defense. First, psychological rehabilitation is a system of psychological influence on a patient with the goal of forming psychological attitudes of rehabilitation, adherence to treatment, cooperation with staff, activity in treatment, attitudes of a healthy lifestyle aimed at achieving mental adaptation of patients after a stroke to living conditions under the influence of special developmental-oriented programs of psychological assistance to patients at each stage of rehabilitation and the formation of a rehabilitation psychotherapeutic environment of the department. Second, the consequence of the illness manifests in physical dependence on the help of other people, self-service and working disorders, and the violation of higher mental functions. The reaction of the individual to disease are psychological factors leading to maladjustment of the patient and complicating the formation of rehabilitation settings. This was about the mechanisms. So the second and third, so the reactions of the individual to consequences of the disease are a reflection of changes in the most significant spheres of psychological relations at each stage of rehabilitation. Violation of the integrity of the I, social roles and connections, change in values and meaning of life. Then that's third. The concept of psychological. The fourth is concept of psychological rehabilitation developed on the basis of a theoretical and empirical assess of research results from the standpoint of a biopsychosocial approach. Allows to identify changes in the most significant areas of psychological relationships of the individual at each stage of rehabilitation, analyze the dynamics of the personality relationship system, and take into account the problems of adaptation. And the results are the following. When you compare then indicators differ in men and women. In women with a left hemispheric lesion, indicators of the distribution of attention are lower than in men. P equals 0037. Constructive thinking, P is less than 001. Interpretation of proverbs, P is less than 0.001. Generalization and abstractions, P is less than 0.05. In women with right hemispheric localization of the focus, the indicators of constructive thinking are worse. P is less than 0.05. So therefore, different adaptation and rehabilitation programs should be the correlation analysis also was carried out of the but also we would like to now focus on the quality of life indicator, the reaction, the quality of life is boosted by the if the right hand is not impaired. We also results. We also did the factor analysis, and the following results in patients with localization of the focus in the left hemisphere factor 1. Verbal logical functions are problematic in patients with localization of the focus in the right hemisphere memory and constructive thinking. Factor 2. The factor of depression and anxiety has the second place in severity, both in patients with localization in the left and in the right hemisphere, and indicates the same severity of experiencing the consequence of the disease by both. The factor of self-service in patients with the left hemisphere functions includes an indicator of memory. In patients with the right hemispheric focus, it is an indicator of constructive thinking, which indicates a significant dependence of self-service on individual indicators of higher mental functions. So the reaction the results of the study of higher mental functions obtained by us allow us to conclude that it is necessary to form special programs for the psychological correction of higher mental functions, taking into account the localization of the lesion focus, gender, and the degree of a decrease in self-service. Patients with varying degrees of decrease in self-care and disability differ in the severity of violations of higher mental functions. The phenomenological and the factor that they lose not only the psychological but also cognitive self. The results of psychological problems there are different stages of psychological rehabilitation and need to use different programs of psychological assistance aimed at correcting higher mental functions, emotional state, attitudes toward illness, treatment, and self-attitude. And so this all contributed to the model of of rehabilitation. The following position number 3, is the reaction of the individual to the consequences of disease are a reflection of changes in the most significant spheres of psychological relations at each stage of rehabilitation: violation of the integrity of the I or self, social roles and connections, change in values and meaning of life, manifest in violation of adaptation in the form of negative self-attitude, depressive and hypochondriacal reactions to the consequences of the disease, have a significant impact on the patient's involvement in the rehabilitation process. But when comparing the personal characteristic of patients with the left and right hemispheric localization of the lesion on the MMPI scale, no significant differences were found. When comparing the indicators of men and women, when studying the MMPI indicators in women compared with men, there's a significant increase in the MMPI-F scale, which indicates a greater internal tension. In women, an increase on the 6 MMPI scale, which is characterized by a more pronounced tendency in them to get stuck on negative experiences, to the effective saturation of experiences. Significantly high in women are indicators of anxiety on the Taylor scale. According to observations and conversations, women are more successful than men at rebuilding and changing cognitive and behavioral lifestyle. Women plan to change their attitude towards themselves, I will love myself more, I will have more rest, and towards others as my children want, let them live. Now women are more inclined to reflect on the life reasons and led to the disease that led to the disease. It's my own fault. I took too much on myself. I thought I wouldn't be demolished, etc. Joint participation in a group of women and men, discussion of attitudes towards treatment and illness, values of life was a teaching factor for both men and women. The positive attitude of women towards treatment with patience and hope was an inspiring example for men, while a philosophical attitude towards their life goals, restraint, and discussing the disease self-sufficiency of men was an important information for thought for women. The indicators of social introversion of patients of group 1 lungs are close to those of patients of group 3 severe, as necessary with ward neighbors, with staff, and only with the next of kin. And they explained the social isolation by not wanting to appear sick in front of colleagues, acquaintances. Correlation and factor analysis was carried out. The indicated attitude to illness has negative correlations with the MMPI indicators. The MMPI HS hypochondria scales, MMPI D depression, MMPI high hysteria, and MMPI PT psychasthenia, and a positive relationship with the indicated attitude to treatment plus 0.524. The indicators of attitude to disease, acceptance of the disease, are the higher and less pronounced hypochondria, depression, emotional activity, demonstrativeness, and psychasthenia. Psychological correlation that attitudes towards the disease will also contribute to the formation of positive attitude toward treatment. The concept the concept of psychological rehabilitation developed on the basis of a theoretical and empirical analysis of research results from the standpoint of a psychosocial approach allows to identify changes in the most significant areas of psychological relationship of the individual at each stage of a rehabilitation, analyze the dynamics of the personality relationship system, take into account the problem of adaptation, identify targets of psychological impact, and implement the most appropriate personality-oriented programs of psychological assistance. Based the stage of psychological rehabilitation have personality-based guidelines. Stage 1 from 2 to 6 months after disease. Severe physical dependence is characterized by motor, cognitive, sensory impairments. Psychological assistance at the first stage was carried out individually and was aimed at correcting self-attitude and restoring the integrative image of self. You can see different stages here. Stage 1 is the stage of intrapersonal correction. Stage 2 from 6 to 12 months, partial physical dependence. Psychological problems were associated with loss of former social roles, changes in interpersonal relations in the family. The psychological assistance program was aimed at helping in the awareness and acceptance of a new social role, the correction of interpersonal relationships. The second stage of psychological rehabilitation, the stage of impersonal personality correction. Stage 3, more than 12 months after the disease, slight physical dependence. The leading psychological problem in patients was the problem of the loss of the old values of life and the need to form new life values and the meaning of life. The third stage of psychological rehabilitation is the stabilization of relations and growth of personality. And so we have statement 6 then, comprehensive program psychological rehabilitation developed from the standpoint of a biopsychosocial approach and representing a system of psychological emphasis on the patient, are aimed at the formation of psychotherapeutic attitudes of the micro-society community of patients, relatives, and medical personnel. When developing programs of psychological assistance to patients, we relied on the provisions of Masishev, development ideas in the works of Karvasarsky, Alexandrov. Approbation of structural dynamic model of psychological rehabilitation, the personal-related programs, psychological assistance developed on its basis at each stage of psychological rehabilitation demonstrated a high degree of effectiveness of the measures taken, contribute to the formation and psychological adaptation of patients, their involvement in the rehabilitation process. So, comparison was made of the psychological indicators of patient before and after the psychological assistance program, using students and Wilcoxon's test, using McNamara's criterion. 302 patients participated. There's a positive trend in the Bartle scale, quality of life, attitudes towards illness, attitudes towards treatment, as well as on the Dembo-Rubinstein self-assessment scale. Based on the results of cluster analysis, clusters were identified that indicate a shift in emphasis from social frustration to training, to egocentricity, holistic self-perception, and self-leadership. Conclusions, I will not read. Thank you very much for your attention. Do you have any questions based on the the presentation? Please. Thank you very much for the presentation. Could you tell me, you have a big a list of factors that influence the further rehabilitation of patients: gender, severity of ailment, the focus, loci. What is the most important factor of all these for the psychological rehabilitation? Or are they equal in their importance, purpose, and results? The first question and the second question. The second question, yes, these are patients who are supported by doctors, psychologists. What was the role of the mechanisms of cell regulation in the rehabilitation process? And the third question, let me know what new does your research present in the understanding of health of a human. Thank you. The microphone is not on. The functions of connection with the quality of life, and we understood that cognitive self is no less important than physical self. When in interview, as they say, "I'm an idiot," yes, they understand that. They have no reduction in speech skills, speech activity, or other cognitive functions. The self attitude is important. When I came home, I am nobody. I was the breadwinner, and now I forget everything. All my he lost his status in family, and this was very important. This was a very important factor for the self-awareness and self-recognition and the position in the family. This I understand, the cognitive self becomes more important than the gender and other characteristics. This is the core on the basis of which you can build rehabilitation. On the other hand, we understood we looked at the personality. Even if she has speech impairment, they have a personality. We have to take account of that. There's a special relationship. They have a relationship with their relatives, etc. You have to work with personality, even if they have speech impairment or loss of memory. Mechanisms of self-regulation. In patients, they look at themselves in a certain way. This gives us information at which level of problem they are. If they say, I'm nobody, I'm an idiot, I can't do anything, we understand that the patient is at the first stage, disintegration of a person. They've lost not only sensory functions, because they say that my memory is not mine, the body is not mine. The first stage is very difficult. We try to get the patient to mobilize. Self-regulation, I said, in women it's a better developed quality. They can accept change. They can accept the value of health, and we try to tell men and women. Men will talk about philosophy and politics, but never discuss health in group meetings, whereas women discuss health, and they accept their illness, and they accept treatment, and they give a good example to men in this regard. So mixed group work is very fruitful. As far as health, this is part of our work. This is very important. Neurologists tackle this. We teach them to accept their health, first of all, to refrain from previous habits, fat food, smoking, drinking, and we also try to develop in them a possibility to understand and accept their new way, what they can do now, what they should do now. So, and then prevention of further problems is important. So, and the support, the main thing is the understanding of the value of health. If they leave us with this recognition, they will improve faster. If they don't believe in this, our the progress that they made in the hospital will vanish. Yes, I'm satisfied with the answers. Another question. Can we look at the table with the stages in correlation with the time that has passed since the stroke? Just a second. Stages. There's a table. Well, may I get help, because I cannot move the slides. I pushed something wrong, the wrong button. Next. So,
Нет, можно я посмотрю это?
Okay. Moral. This is the model of rehabilitation. This in the second column, there's partial independence, full independence after 6 months. If they not self-reliant or self-service is low, will he not pass the second stage? So, but if the person is not cannot serve themselves, this is about psychological rehabilitation. That we're not talking about order 705. These are the stages. The restoration of moving motor functions. We conditionally separate different. We focus here more on the severity of impairments. If their physical dependence on others is high, they're still at the first stage. The psychological state will be very, very bad when they start walking, even on the cane or with support of others. They will feel better, and their psychological state will be different, and they are then transferred to the second stage. If they're a bed-ridden patient, then they're not accepted to the inpatient facility. When they start working, they will be, and outpatient facility. Sorry, they will be. We include for such patients in their group therapy is the therapy of action, art therapy, physiotherapy, supporting types of therapy, and of course individual correction is by a psychologist, and supporting therapy in a group. Well, we talk about the left hand, but the right hand will still be unworking, unworkable. Then if only one hand is working, will they be stuck on the first stage? No. If they walk, then they can move on, because when they start moving, walking, their hierarchy changes. They will start trying to find a different hierarchy of values. Well, they were chief engineer, but and then they start writing memoirs, for example. Their depression wanes, and well, they're moving in terms of personality awareness. They found a new purpose of life in men, for example, especially for military. After a severe stroke, they cannot work in the garden or do things around the house. Therefore, relatives and psychologists need to help this person. Even, it may take even a year or over a year to find a new purpose of life, a new place in life. Well, as I understand that, irrespective of the time since the stroke and other characteristics, the psychology, this patient will have to treat them at 3 different stages. Well, the terms, the times are quite relative, because this is most prevalent time in our observations, but it may take longer if a person, for example, is ignored by the family or other negative factors. Well, 3 stages. We just identified these 3 stages. These are conditional traits. Well, is someone takes only a half a year if the stroke was not that severe to get through the 3 stages, but some will take 3 years, and so but we are this is dependent on their physical capabilities, and some people again will think of them as healthy, as completely well, even with objective impairments. We tell them it's great that they have self-awareness, such positive serum, but they have to undergo treatment anyway. So I would like to say that all the reviews have been published on the website of the of St. Petersburg University. Therefore, I suggest that only key comments and questions be read. Valentina Anatolyevich Ababkov, dear Nataliya, dear colleagues, the relevance of the topic is determined by a high frequency of in the world and in our country of impairments of brain, blood circulation, and also difficulties of treatment and rehabilitation of patients with such an ailment, including due to a less than adequate studied role of psychological factors in the process of rehabilitation. According to the literature, the number of strokes in Russia numbers 450,000, higher than the European Union and the USA. And therefore, I would like to say that the results of research are written down in a very clear and logical way. The results of we can say that on the basis of the research, the author identifies different programs of rehabilitation. Well, these comprehensive programs of psychological assistance or support are valid and are applicable in healthcare. Well, I will skip the formal things and so the scientific provisions, conclusions, and recommendations are verifiable or valid, and that because they're based on large scale of research, and using scientifically valid theoretical provisions, and the scientific significance lies in the fact that there's the author describes a comprehensive psychological portrait of patients. The materials of the dissertation prove that a program of scientific research has been compiled and implemented by the author, and that the research is original, that the empirical data was statistically treated, and the dissertation has a traditional structure. Has tables and figures that makes a contribution to the ease of reading. The quality on the volume of material, the research design, the methods are relevant to the goals and objectives of the work. As far as the critical comments and questions, then you can see that the research the research has some failings in terms of spelling or other typos and mistakes, and then conceptually the content it's not conceptual, but the contents like chapter 2, and in terms of the conceptual drawback, the goal is to create a concept of psychological rehabilitation of patients with a stroke after a stroke. This hasn't been implemented, achieved in full, and because practically a very important scheme and algorithm of such a rehabilitation lacked a clear theoretical methodological substantiation. And there were two stages of research, but at each stage the number of patients is different. The conclusions will not always refer to the importance of or the value of the implication of the research results. And then there are quite a few journal provisions, and the focus on the original research is sometimes very vague, and also we can see that the dissertation took a lot of years to complete, and of course this is reflected in its in its complexity. And therefore, nevertheless, I have three questions. Which theoretical approaches are principal for this work as a Doctor of Science dissertation? Second, why do you have different numbers of patients and at different stages, and how can it impact the obtained results? How is the psychological rehabilitation that you propose connected with medical and social rehabilitation? But the conclusion is that the dissertation of Nataliya Georgievna Ermakova on the topic of psychological rehabilitation of patients with the consequences of stroke in a rehabilitation hospital complies with the main requirements of the procedure of awarding academic degrees at St. Petersburg University, and therefore Nataliya Georgievna Ermakova deserves to be awarded an academic degree of Doctor of Psychological Sciences in the degree field 19.00.04 medical psychologist. So the plagiarism condition is not violated. I would like to answer your critical remarks. The first one is about the location designation of Chapter 2. Chapter 2 is indicated in the table and context on page number 2, and the chapter itself is located on page 132. Remark: Theoretical methodology foundation research. Answer: in the section Theoretical and Methodological Foundations of the Research, first place is given to this biopsychosocial approach, which is the leading direction in modern medical and psychological rehabilitation. Also in our research, our study followed a biopsychosocial approach, medical rehabilitation, biological and physical methods of exposure, drug therapy, exercise therapy, physiotherapy, mechanotherapy is aimed at preventing the defect, psychological and social rehabilitation of the patient's adaptation process. Psychological rehabilitation, to which our research is devoted, was aimed on the one hand at helping the patients and their adaptation after a stroke, and on the other hand at creating environmental therapy, psychological work with the relative staff and the patient community. This is the social aspect of the impact in our study. This diagram, this is very important for the especially when the relatives asked us how should we help this person, and the same thing with medical staff, and this is the social assistance, registration of disability patients, and so this diagram is presented in chapter 3, section 3.4. Psychological assistance to patients, microsociety, and patrons of medical procedures through the work with the community of patients. Social assistance, as I said, well, a patient is in a rehabilitation hospital, is less representative, mainly including after the patient is discharged from the hospital to their home. When forming the concept and model of psychological rehabilitation, we considered all the approaches described, since they contribute to the construction of an empirical study to identify psychological problems of patients during the formation of stages of psychological rehabilitation and targets of influence when building programs of psychological assistance to patients after a stroke. The study identifies personality-related stages of psychological rehabilitation, which are really presented for the first time, and they're not in foreign literature. At the same time, we were guided by the following approaches: the principle of the unity of biological social in the development and formation of a person, Banshikov and Lomov, the concept of mental adaptation as a systematic activities in biological psychological subsistence, Alexandrovskaya and Berezin, the concept of all the levels of regulation in biological, individual, personal, environmental, Ananyeva, theory of functional functions, Anokhin, the concept of the theory of relations by Mesisheva, and the stage of the personal growth, the doctrine of higher mental functions, and the concept of systematic biological and physical subsistence. Some foreign rehabilitation scholars believe that the higher mental functions, the correction of higher mental functions is not necessary, whereas Komskaya and Vygotsky and Luria think that our scholars think that it is. I think in recent years, memory correction programs have appeared. Neurocognitive rehabilitation, cognitive training, and different broad programs are focused on cognitive rehabilitation, neurophysiological rehabilitation, Wilson and Evans, and form a goal and after have a pharmacological aspect of the correction of depression and anxiety. And the main task of the method is to form a real goal of restoration. These workers, Wilson and Evans, they worked with patients after an injury, and that's different type of study. The third on the purpose of research, creation, the concept of psychological rehabilitation principle, the consequences of stroke. The chapters 1 and 3 of the study devoted to the creation of a concept, model of identification of stages of psychological rehabilitation. The conclusions obtained in this studies are presented in Chapter 3, Remark 4 on the scientific knowledge of the research. The main result of the work, as already mentioned, is the allocation of personality condition division into stages of psychological rehabilitation, violation of the integrity of the self, and the problem of stage 1 is the problem of stage 1, social roles and connections is the problem of stage 2, change of the values and meaning of life is the problem of stage 3. So for the first time, the leading psychological problems at each stage of psychological rehabilitation are revealed. And so the theoretical significance of the study lies in the development of medical and psychological aspect of psychological rehabilitation of patients, associated with the clarification of the mechanisms of mental adaptation and the dynamics of the patient's personality relationship system at each stage of adaptation. The adaptation of programs, thematic-oriented training, coping with stress in relation to patients after stroke, presented in Chapter 4, was also carried out, and these programs are tested, presented in Chapter 5. Remark about the number of patients participating in the study. A total of 1,042 patients after stroke were treated in the rehabilitation hospital. In 115 patients in an outpatient facility, and participated in a total of 157 patients. This is described in the text of the thesis, both in the introduction on page 21, and Chapter 2 on page 136, and pages 152-152. Out of 1,042 patients, 740 were studied at the stage of psychodiagnostics. The results are described in Chapter 3. As far as the questions are concerned, the first question: what theoretical approaches are fundamental for the scientific work in the form of doctoral dissertation? As already mentioned, the biopsychosocial approach in rehabilitation, Bechterew Angel, the concept of the system of personality relations by Messish, Second, what is the reason for the large scale large scale of examination at different stages? Based on the study of domestic violence, that's why identified that impede rehabilitation treatment, somatic factors, severity of condition, non-committal diseases, movement disorders, level of self-care, then the cognitive factor. At first, an empirical study was carried out to study the state of higher mental functions in patients with different hemispheric localizations of the co-focus, in men and women and patients with different severity of the condition, and studied the relation between indicators of higher mental functions and indicators of rehabilitation success, quality of life, and level of service. The personal traits were studied using experimental psychological methods and interview analysis. The same psychologists and the same doctors worked with all the patients. So, but they were different in somatic factors and cognitive factors. As far as the how is the psychological rehabilitation offered by the author related to medical social, our studies follow the bias psychosocial approach. The patients received comprehensive rehabilitation treatment, medical rehabilitation, biological and physical methods of exposure to drugs and exercise therapy, mechanical was aimed at preventing the defect. Psychological and social rehabilitation for the patient's adaptation process, and so in general the biased psychosocial approach assumes the unity of the effects on the patient depending on the severity of their condition and the stage of rehabilitation. So psychological rehabilitation involved different stakeholders, and if we compare a hospital inpatient and outpatient facility, and the conditions are different and the indicators will be different. Are you satisfied? I accept the answers. Kraspinsky Konstantin Viktorovich, please. Dear colleagues, dear Nataliya Georgievna, I will just briefly mention what I want, because my review is published on the website. I would like to say just the dissertation of Nataliya Georgievna fully meets the requirements of the academic research and the specialism 1904 medical psychologist, and this the relevance is in the fact that the morbidity was very high, mortality, and people become patients with after stroke become impaired for life, and so the significance is that it works towards the return of the patients to social life, full socialization, and of course it's good for the patient and good for society in terms of economics, for example. The structure of multi-level personality is a multifaceted result, and both in organic and cognitive impairments, and in the secondary personality destruction, changing the change of our customary lifestyle for a person, and the loss of the purpose of life, and other things. As the treatment of psychological rehabilitation is a process of supporting a natural activity towards a multi-level adaptation, and we should deblock the process of catering, of a person catering for their needs. The novelty of the research, I think that this is the first research in psychology, Russian psychology, based on the analysis of a big array of data. The author systematized of consequence of a stroke as a somatic illness, and that make it impossible for the person to fulfill basic tasks, and when restoring mental activity, and the author could assess individual psychological factors that also determine the rehabilitation process, and she comes up with concrete measures, rehabilitation measures, to make them adapt to a new life situation, and create positive trends in their personality changes. And it has the research has a methodological foundation and empirical study in rehabilitation in inpatient activity. So theoretical, empirical, and methodological foundations make me believe that this is a high-level research worthy of Doctor of Sciences level. Well, today's psychology, of course, is enriched. The work has rich psychotechnical and heuristic potential for some clinical psychological theories, and for example, the theory of higher mental functions, the theory of relationships, and for neuropsychology there's an input, because it talks about the impairments of high mental functions depending on the left or right hemisphere damage. New knowledge this new knowledge on the mechanisms of functioning of a patient in fighting and in disabling ailment. These programs of clinical psychological interventions have been tested empirically and in compliance with the standards of verification of psychological intervention. Well, the scope of literature review, non-contradictory of theory and empirical study. So this all speaks in favor of the research. The work is very well done. It took a number of years. There's history of publications. As far as the structure of the dissertation, it's traditional. My evaluation of this dissertation is very positive, but of course there are some drawbacks that I can express in the form of critical remarks and recommendations. The first one of the tasks of the dissertation is formulated as to study the influence of the gender of the patient on the success of the process of rehabilitation, page 11. I think that this task and the subsequent interpretation of the empirical data is not accurate in methodological plane dimension, because the status and the gender variables do not explain normally the mechanisms and the rules of determination of mental development and the functioning of a person, including in rehabilitation after a stroke. The determinant variables are usually biological and social cultural factors that are connected to age and gender, which generate a spectrum of intergender and inter-age differences, including in the in terms of the success of the restoration of mental functions and forms of activity destroyed or damaged by the stroke. And the second, when you describe psychological consequences of a stroke and the psychological problems of everyday life that are present in post-stroke patients, you limit yourself to the methodology, and the terminology of medical psychology, but the spectrum of these consequences, the problem, are much wider, and these are different levels and spaces of development and functioning of the patient as a biological human, the biological individual, a social individual, and a personality. And third, the style of the formulation of some chapters and sections. For example, paragraph 3.1.4, a study of the results of a factor analysis. Paragraph 4.2.1, a study of the results of a comparative analysis. And I think that the object of study in any psychological study is some mental reality, and different types of analysis and their results serve as means and foundations rather than the subject of the study. Nevertheless, this doesn't diminish the value of the dissertation. Therefore, my conclusion is that the dissertation of Nataliya Georgievna Ermakova on the topic psychological rehabilitation of patients after a stroke in a rehabilitation hospital complies with the requirements of the procedure of awarding academic degrees in St. Petersburg University. And the candidate Nataliya Georgievna Ermakova deserves the third degree of a Doctor of Psychological Sciences to be awarded to her. Can I answer? Dear Konstantin Viktorovich, and for your, I will agree with all your comments and suggestions. I totally agree with your comments. Are you happy with this? I am happy. Thank you very much for your concise answer. Karavaeva Tatiana Arturovna. Dear colleagues, dear Nataliya Georgievna, I would like to point out the relevance of this a stroke is the death of neurons in the locus of damage, and therefore this is not an ailment of old age, but a working age. It affects the working age patients too, and the strokes now hit younger people. The different stages of rehabilitation and the contents of the stages are what our healthcare needs to treat these patients. Important in this work is the comprehensive character and multi-layered approach, because it allows to look at this phenomenon of rehabilitation of patients after stroke from different angles. I will not read the whole review. The dissertation is written at a high level. New results. It presents new results. And it enriches the clinical practice. I will just read my critical remarks. the stroke influences patients' experiences and anxieties.
Мероприятий. Также либо если какие-либо интервенции, направленные на повышение, какие у нас причины отказа в прекращении участия. Третье. Какие с точки зрения
Объявляем
Technical break number 2. Are all the patients, including the programs, have all undergone treatment?
Татьяна Артуровна, есть предложение озвучить вопросы. Текст не нужно говорить. Пожалуйста, еще раз. Вопросы. Только вопросы и замечания озвучьте. Она не слышит.
Валентина Михайловна, надо технический перерыв объявить.
Ну, давайте перерыв.
Пробуем связь остановить.
Перерыв.
Вот,
Коллеги,
так.
Слышно?
Да, да. Сейчас тогда,
Коллеги,
Валентина Михайловна, объявите книжки
я
закрытым.
зачитала вопрос.
The first one is that the first author says that psychological constructs that seriously affect the effectiveness of rehabilitation is the internal picture of the disease, is the attitude to the disease, attitude to treatment. The second is the effectiveness of rehabilitation. Rehabilitation measures is dependent on the motivation of patients to get involved in them. Have you had any patients that would refuse to participate or stop involvement, and what were the reasons? Third, what methods of psychotherapy and psychocorrection are better to use for this type of patient? Maybe in deep methods of psychotherapy, maybe supportive approaches. My critical remarks or questions do not diminish the quality of the dissertation, and the dissertation of Nataliya Ermakova comply with the procedures of the procedure with the requirements of the procedure of awarding academic degrees at St. Petersburg University. And Nataliya Georgievna Ermakova deserves the third degree of Doctor of Psychological Science to be awarded to her in medical psychology. Thank you. Nataliya Georgievna, please answer. Dear Tatiana Artur, thank you very much for the answer. First question about the internal picture of the disease. We studied the attitude towards the disease and the attitude towards treatment according to a specially developed scale, and also studied the quality of life. A comparative correlation analysis of indicators was carried out and described in chapter 3 of the dissertation. The study of correlations revealed high correlation of the indicator attitude to illness with anxiety and depression, attitude to the disease, acceptance of disease, and readiness to perform procedure is significantly higher in patients with a lesion in the left hemisphere, higher in men compared with women, with the left hemispheric localization of the lesion. In patients with the right hemispheric localization focus, there is no difference in this indicator in men and women. The attitude towards the disease is high in lighter patients with a high level of self-care. As far as the correlations, and as I said, and anxiety and depressions are important. With reactive anxiety in patients with left hemispheric localization of the lesion, they have right-sided paralysis and speech disorders. the high interconnection of the indicator of attitude to the disease with the indicator of the attitude to treatment indicates that it is the attitude to the disease. It's acceptance that is decisive in the formation of adherence to treatment. Study of the experienced patient attitude to treatment to oneself to the environment was also carried out with the help of clinical interviews and the phenomenological analysis of the statements of patients of the first, second, and third stage psychological rehabilitation, described in paragraph 3.3. Identified cognitive, emotional, and behavioral aspects of relations, studied their dynamics, which is described in chapter 5. In the process of psychological rehabilitation while undergoing psychological assistance programs, a positive dynamics of attitudes towards illness and treatment was noted. There was an acceptance of the disease, acceptance of treatment, acceptance of oneself, one's own a new social role, a new meaning of life. If adherence to commitment to treatment does not occur, the patient refuses treatment, does not take medications, violates the cholesterol diet, does not monitor blood pressure, does not give up bad habits, smoking, alcohol, then the restoration of the impaired functions does not occur. The patient remains at the first stage of rehabilitation, and as a rule, a second stroke occurs. Therefore, in order to make a patient prevent that, we must teach him to or her to accept themselves. Well, this is the first stage. In terms of motivation for treatment, a program of individual psychological assistance was carried out with stage 1 patients aimed at correcting the goal of the subjective requirement program. If the patients set for themselves a high and unreal goal that they could not achieve based on their available capabilities, the patients fell into despair or depression. We set the task of adjusted the scale and sequence of achieving the goal in the patient's mind, orienting them towards achieving the goal step by step, not immediately learn to walk, but first learn to stand, then walk with support, and then walk independently. Reaching immediate goals, the patient receives pleasure and positive reinforcement from their efforts, and this increases motivation. Therefore, stage 1 is the correction of goals. Second, who did not participate, reasons for leaving the program. Now study at the stage of psychodiagnostics, that the stage of development and testing of psychological assistance programs. Initially, much more patients took part. In the final version, at the stage of psychodiagnostics, patients entered who were able to complete all tasks of psychodiagnosis, 740 patients. A strict selection of patients was carried out. Patients with severe cognitive and motor impairments and those who did not want to participate in the study were not included. Informed consent was obtained from those who expressed a desire to participate in the study. Of those who expressed the desire, not everyone was able to complete all the tasks for semantic and cognitive reasons, either rapid fatigue, worsening of the condition, raising blood pressure, headache, difficulty understanding the instructions. Even if they completed some of the tasks, this data was not included in the study. Some of the patients could not complete all the tasks. Either the patient was quickly discharged and transferred to another department, or did not have time to complete the entire range of tasks. The data of these patients was also not included in the study. I think I answered all the questions. Third question, maybe? Yes, third question. According to priority methods of psychotherapy and psycho-correction. According to the literature, methods of humanistic behavioral psychotherapy are most acceptable for patients after a stroke without a deep study of the problem. In our study, we focus on study correction of patient's personality change with the stage of psychological rehabilitation and correction of these relations. We use personality-oriented psychological assistance. For example, the first stage, the task of correction, is self-acceptance, acceptance to disease of treatment, and so on. Confrontation is also possible at individuals who work at stage 1. When a positive contact with the patient is established, usually in patients with asthenoneurotic reactions to disease, disbelief in recurrent treatment, disbelief in their strengths. At the second stage, interpersonal problems of adaptation were identified, and at the second stage, we applied thematically oriented training in a group setting. And the subjects were asked by the patients themselves relations with relatives, around the environment, public transport. We used role play and difficult situations, etc. At the same time, it was not a free discussion, but a discussion guided by a trainer. And the second stage, the people who were involved, who wanted and could discuss their problems with others. If they couldn't for physical conditions, then they received individual treatment. And so the second stage, in a working group, confrontation is possible, which is carried out both the trainer and by the group members themselves. Stop moping. You will work out your hand and everything will recover. You get sick, you need to be treated. There's nothing to whine about. And the most advanced patients who became convinced by their own experience of the possibility to recover became the conductors of positive ideas. At the third stage, the problems of restructuring of value orientations were also discussed in the group. Changes in the values of life were more easily accepted in the older age group when the problem of transition to retirement and had already been resolved by the children, and the children had grown up. Restructuring in women was easier. So patients noted increased vulnerability after stroke, fatigue, sleep disturbance, and mastered the technique of coping with stress. So the second stage, we have to go back. We used a guided discussion. It was not a free discussion because it could lead to the jump in arterial pressure, and therefore and so the confrontation in the working group is possible, and and I think that this is this again, the importance is the roles of people who had gone through these problems before, and they could be harsher, but they also gave a positive boost to the members of the group that had just arrived at this stage. And the patients they were very vulnerable. This was on the one hand confrontation, and on the other hand it should be very subtle. Thank you very much. Tatiana Arton, I accept the answers, yes. Svetlana Timofeyevna. Dear colleagues, I will not read my review in full about the structure or about the factors and the validity of the results. I will just say that for modern psychological research in medical psychology very often lack the comprehensive picture, and this dissertation is unique in this, that it provides a comprehensive model of rehabilitation. The analytical style of describing the findings makes this research a good resource for the treating of different disorders after a stroke, in patients after a stroke. And all the conclusions are empirically based, and therefore it makes the conclusions practically applicable in medical practice. And the study looks at different types of condition, somatic and others, consequences of the stroke, and the author uses methods of psychological research and also strategies of psychological assistance. Therefore, the author creates a single context of understanding the psychological rehabilitation as a dynamic biopsychosocial phenomenon, a structural component organization of which determines the possibilities of mental adaptation of a patient after a stroke. The scientific originality of the work is determined by a research problem because it's an understudied program, and the novelty is in the theoretical and empirical grounding of a multi-component structure of psychological rehabilitation. Psychological rehabilitation is determined by the conditions of higher mental functions, the traits, the personality traits, the gender, and the hemisphere localization of the damage, and the system of the behavior or attitude at different stages of rehabilitation. This model is directed to help people with impairment of self-care. I would like to draw your attention to some critical remarks. Some questions too. First of all, the dissertation focuses on the development of a model of psychological rehabilitation with post-stroke, and of course it's a socially important illness, but how specific to this category of patients are the psycho-rehabilitation dependencies, and can they be extrapolated over other ailments and diseases? And the second one is the dissertation is structured, is based on pathocentric focus of Russian medicine, and therefore the author looks at the internal picture of the patient. But how can this internal picture of health? How can the internal picture of health be created, and how is it embodied in their conscience? Third one is that the goal of the rehabilitation is in ensuring social psychological adaptation. Is there any cases of successful rehabilitation after the rehabilitation period in an inpatient facility? The big volume of dissertation is of course is due to a huge amount of research material, but probably some elements of models of psychological rehabilitation should have been put into appendices rather than kept in the text. Nevertheless, the conclusion is that this dissertation of Ermakova Nataliya Georgievna complies with meets the requirements of the procedure of awarding academic degrees at St. Petersburg University, and the author deserves the sought academic degree of psychological sciences to be awarded to her. Dear Svetlana Timofeyevna, and and answer the first question. In our opinion, the disclosed patterns of psychological rehabilitation carried out in a rehabilitation hospital can be extended to the rehabilitation of patients after stroke on an outpatient basis in rehabilitation centers for distribution to other groups of neurological patients with the consequence of TBI, multiple sclerosis, the consequence of tumor removal, ALS, etc. At the same time, additional research is needed on patients, into patients with this nosological form. Our experience of psychotherapy group and individual with neurological patients with brain disease, for example, the consequence of TBI, etc., removing tumors with the consequence of spinal trauma indicates a pronounced nosological specificity to experience the internal picture of the disease. Our experience with group psychotherapy shows that the formation of groups requires strict nosocentricity. Thus, patients with the consequence of a stroke are ready to understand and accept each other in a group, even patients with tolerant sensory aphasia, to provide assistance. You emphasize, but are not ready to understand and empathize with patients with the consequence of TBI, or because they don't know these diseases. The patients with the concept of TBI easily understand each other's feelings, react to their fears, describe the experience of after coming out of a coma, while the experience of patients after stroke seem boring and incomprehensible to them. So therefore, to extend this to other nosological groups of patients at the stage of rehabilitation, neurology and cardiology and pulmonology, etc., it is possible to take as a basis the multidirectional effects, work with patients, work with microsocial environment, relatives, medical staff, community of patients, to create a psychotherapeutic environment that creates a positive atmosphere of support and empathy. And for the dynamics of personality relationship at different stages of psychological rehabilitation, here, as we see it, additional research is needed with this category of patients. As far as the terms of there's a connection with successful life situations of discharge from hospital. According to for example, according to observations, women are more successful than men, and well, the main thing is that we should teach them to weigh their cans and cannots and wants. That's the question. That was the question about the internal picture of health, restricted to bad habits, etc. And third question about the discharge from the hospital. Women are more successful than men at rebuilding and changing cognitive and behavioral lifestyles. Women plan to change their attitude towards themselves. I will love myself more, I will have more rest, and towards others, I will let my children live the way they want. And women are more inclined to reflect on life reasons that led to the disease. And joint participation in a group of men and women, discussion attitudes towards treatment and illness, values of life was a teaching factor for both men and women. So, as far as the fourth question, I agree with your fourth comment. Thank you very much. I am happy. Irina Rudolfovna, I will not read the whole review. The scientific novelty is in the description of personal response to the disease and treatment, and the data is huge. This empirical study is very, very voluminous. The center of the correctional correctional intervention, the center is the attitude of the person to the treatment, etc. And this is a person-centered approach, and the creation of the environment, the healing environment, and the target of influence is the acceptance of oneself and changing the attitudes to others and finding a new purpose of life, and leading psychological problems were described inherent in every stage, in each stage of rehabilitation, and self-care is the key criterion that was identified. The author, therefore, theoretical importance in the dynamics of the author formulated of different psychological intervention. First of all, accepting oneself in their one's new social role, and correction of and re-evaluating of the relationships with others. The model of psychological rehabilitation can be used by psychologists to build their own programs of psychological assistance in group and individual settings. The applied significance is the modified group methods of psychological correction adjusted to the patients of this group, and this can be used with all disabled people. It was very many patients, over 1,000 patients were studied, and this work is in Russian, of 490 pages. It's a huge volume, and with the English translation, it's close to 900 pages. The author was very patient in conducting this work, and this was very hard work with very difficult clinically difficult patients. This work has many drawbacks because of the volume. So because sometimes the data is not logically presented, or is not, the narration is not coherent. And for author sometimes, well, couldn't align the conclusions with the goals. And why do we so the text is overloaded with comparative tables. You should have put in the appendix. Methodologically, it's sometimes vague. The author adheres to the social approach. There's no connection of psychological rehabilitation with the traditional concept of medical rehabilitation. As a result, there's a confusion because the stages of psychological rehabilitation are not aligned to the stages of the comprehensive medical rehabilitation. I didn't understand why the method of MMPI was used. Why do you use such a laborious method with light patients with in the system, the patients of vascular damage, they would probably not have a disorder of character. And my questions: how do you align, therefore, the 3-page psychological rehabilitation with the goals and the tasks of these stages of rehabilitation, which are set in the procedure of management, administration of medical rehabilitation? That's Ministry of Health Care of Russia, dated on the 29th of 2012, and the author divided patients at the beginning into 3 groups, depending on the level of self-care, ability to care for themselves, and pronounced disorders. Does it mean that the 3 stages of psychological rehabilitation do not depend on the duration of the period of that passed after the stroke, and then the structural functional model implies 3 these subsequent consecutive stages of adaptation to the disease. Is it true, or is it just 3 different forms of work for the psychologist, our psychologist with a patient? How did you rate the effectiveness of the programs if you had no reference groups? What is the novelty of the method, the narrowing and concretization of the goal, if a lot of literature exists on the topic? Wilson, Evans, Ewans, etc. And the SMART approach is used also. And then there's no novelty in conclusions number 1 and number 2. they are more of a general reasoning. Yes, I would like to about the first the provisions for defense. I think you answered this question. I would like to say that, and the first provision, there's a definition. Psychological rehabilitation is a system of psychological influences on a patient with the goal of forming psychological attitudes of rehabilitation. Here's to treatment, cooperation with staff, activity, treatment attitudes to health lifestyle, aimed at achieving mental adaptation of patients after a stroke to living conditions. I think there is a novelty, a scientific novelty there. The second, as far as the consequence of the illness, manifested physical dependence on the help of other people, and this is the problematic nature. It was important for us to understand by what mechanisms maladjustment occurs and what complicates the formation of rehabilitation attitudes, acceptance of the disease, adherence to treatment, cooperation style, adoption to healthy lifestyle attitudes. 3. The reactions of the injured to the cause of the disease. This is number 3, provision number 3. Novelty is in the revealed violations of personality traits and its system of relationship. So this is described in section 3.4. The novelty is the violation of the personality traits. Provision number 5, mental adaptation. If in the second provision we talked about the problems of personality, in this we talk about the violation of blocked needs, mental adaptation, and achieving the realization of the needs, or the meeting of the needs of the body and the personality, occurs at different stages and is provided by different methods or influence, biological, psychological, and social, and contributes to the meeting of the needs at each stage. And physical dependence and communication, self-regulation, success, and stage 1. So this is second. Why did we study the higher mental functions? The results of the comparative analysis, especially with left hemisphere, right hemispheric localization of focus, men and women, patients with different levels of self-care, made it possible to identify the targets of psychological influence when building a psychological assistance program. So it was important for the patient to accept their cognitive self, not just physical self. Next, about the factual structure. The results of studied this factual structure, the indicators and mental functions are of primary importance. The process of adaptation to the disease, which indicates the importance of their self so the goals I think are met, and these conclusions clarifying question number 4: how is medical rehabilitation and psychological rehabilitation related? Medical rehabilitation is aimed at preventing a defect, restoring impaired functions using biological methods, medication, physiotherapy, exercise therapy, mechanotherapy. Psychological rehabilitation is aimed at mental adaptation of patients and uses methods of psychological influence and is divided into several stages. We divided it. Comprehensive psychological rehabilitation includes psychological assistance. In our study, the psychologist participates in meetings with multidisciplinary team, and each specialist makes appointments. Individual rehabilitation creates an individual rehabilitation plan for each patient. So and of course, as I said, the psychologist was present at all meetings of the team, clarifying question number by a psychosocial approach. Yes, our work has been done from a standpoint of psychosocial approach. Clarifying question number 6. Why MMPI method was used. The study included patients with preserved understanding of oral and written speech with mild and moderate motor impairments. And the MMPI technique can be used to diagnose psychological personality traits in people over 16 years old. We have 14 and older. We have at least 7 grades of education. We have secondary and higher. Preserved verbal intelligence are not lower than 70 IQ, patients without cognitive decline, for whom Russian is as their native language. The condition is fulfilled. All rating scales LFK in our study were within the acceptable range. And the Minnesota multiphasic personality inventory, created in the early 1940s, helped us to identify mental states. If some evaluation scales coincided with the MMPI, because we created questionnaire based on they. Now, answer to one main question. I think you answered the yes. Well, the inpatient facility, it's usually the second stage. We looked at we studied patients before this regulation was actually issued. There should be different approaches to psychological. The second, different division into stage psychological rehabilitation occurs depending on the severity of self-service disorders, level of physical dependence, the state of higher mental function, speech, emotional state, anxiety and depression, and psychological problems, loss of the integrity of the self, difficulty accepting illness and treatment, cooperation with staff, loss of the social status of the problem, interpersonal relations in the family, microsociety, loss of values, meaning of life. And so the severity of violation depends on the volume or location of the lesion and concomitant diseases. And the number of authors, it does not depend on the duration of the disease. And in that regulation that you mentioned, this is also mentioned. The number of was given the time that has elapsed since the stroke is not the key factor. The third answer to third main question. The work was carried out in a rehabilitation hospital, and the request of patients and doctors was undoubtedly into account, but the assessment of the patient's psychological state, identification of adaptations, problems, assessment of the stage psychological rehabilitation, the choice of psychological assistance program was carried out by a psychologist. The work was carried out until 2012, before the release of the Order 1705 in 2012. The model of psychological rehabilitation assumes the greatest implementation precisely in the conditions of a rehabilitation hospital. Staff actually trusted the psychologist. For example, work with the patient and the social environment, relative staff and the community of patients, and not at the stage of the acute period, stage 1, according to Order 1705. Meanwhile, it seems to us that the model can be implemented at the outpatient stage, stage 3 according to 1705, when the day hospital of rehabilitation and district polyclinic is operating, or an outpatient rehabilitation center. However, the task of testing the model of psychological rehabilitation in an acute hospital rehabilitation outpatient clinic was not set in this study. In an outpatient clinic, we tested one individual correction program and it demonstrated its viability. Fourth question, we have developed programs of psychological assistance at every stage of rehabilitation. These programs have been tested, approved. We needed to check how the psychological assistance programs at each stage we developed at each stage of psychological rehabilitation are accepted by patients, and what dynamics are in terms of anxiety, self-esteem, cognitive functions, as well as the So the statements of patients during clinical interviews before and after the program. And the dynamics, well, in terms of reference groups, yeah, we can do that in further study. Well, but psychological assist programs were found to be effective for this sample of patients. Next answer 5. About the program of individual corrections. This I use this program when working with patients at the first stage of psychological rehabilitation, that is with patients with physical dependence on the help of other people. An individual correction program has the individual has 4 directions of work with patients depending on the problems of adaptations. I used it in 1990. When working with patients after a stroke, and was described by me back in 1990 in the collection of Demidenko, Professor Demidenko, who worked in Bechterev Institute. You can consult this book. In the areas of individual correction, and we're talking about the correction of inadequate attitudes of patients, overestimating one's own capabilities, performing exhausting exercises, excessive workload, lead to complications, or underestimation of one's own capabilities, and their correction, and etc. In 1990, neither the respected Barbara Wilson nor Jonathan Evans wrote anything about goal correction. Wilson devoted her work and research to patients with the concept of TBI. Her work began in 1979 with these patients, and Barbara Wilson, Jonathan Evans, and Badley published an article in 1994. And Wilson 1999 devoted to the problems of memory correction in patients with the consequent TBI. In 2002, the article Rehabilitation of Executive Functions to Promote Effects of Goal Management of Complex Tasks Using Periodic Beeps is devoted to the working with patients with frontal disorders after TBI. Goal management. Goal management was also part of Wilson's work in 2009, and it was applied to business. It came from NLP, a behavioral technique. In rehabilitation, this is called SMART technology, became popular in the 2000s in Europe, in our country after 2010. Shmonin et al., 2019. Wilson's work on SMART technology began in 1979 with patients suffering from emergencies for accidents with the consequences of TBI. Thank you very much. Let me stop you. Thank you. Thank you. Thank you. Thank you very much for your attention. You answered all the questions. I have, this is my time now. my turn now. Well, I would like to talk about some what's the my questions are what is the prognosis of the remote prognosis of recovery in men and women, and what's the sixth? What was the influence of the pandemic on the rehabilitation of patients? About the effectiveness of rehabilitation measures, is about the scales of self-service. It's judged by the dynamics of self-service scales, the dynamics of the quality of life, indicators of the cognitive sphere. These indicators were studied in the course of a study and were compared in patients with different hemispheric lesions, in men and women, in patients with different severity of the disease, described in chapter 3.1, 3.2, and at different stages at the testing of different psychological assistance process. In our study, we studied the medical documentation, medical history, and each patient, which reflected in the patient's condition upon admission and discharge. In the comprehensive rehabilitation program, along with physical methods, psychological assistance was included. In chapter 5, I present the dynamics of indicators of self-service scales, Bartle scale, quality of life, attitude to illness and treatment before and after the course of rehabilitation, dynamics. Second question, specific examples of patient case histories and represented in the appendices. Yes, I agree that these will be illustrative examples. The success of rehabilitation process judged by self-service indicators. There were no significant difference in women and men according to the Bartle and the FIM scales. In patients who with left hemispheric localization lesion, they had right-sided hemiparesis, impaired movements in the right arm and leg. Third, what are the features of the recovery process in men and women at different stages? Answer. Both men and women have an adaptation process at different stages. At the first stage, the loss of restoration of the integrity of the self-identity, and the second stage, interpersonal problems. At the third stage, the problem of changing values and the meaning of life. The first stage indicates of self-service scales significantly in women with right hemispheric localization, the lesion with left-sided hemiparesis. They are more successful at self-service, and patients with left hemispheric localization, there were no difference in self-service scales in men and women. In women at stage 2, compared with men, internal tension, suspicion, and tendency to form overvalued ideas and anxiety were significantly more pronounced. Fourth question. What's the prognosis for the near and distant future in male and female patients? The prognosis of recovery depends on the severity of the condition, hemispheric localization, cognitive decline. And in the distant future, the formation of healthy lifestyle, attitudes, rejection of bad habits, fatty foods, regular medication, blood pressure control, which is the prevention of current. And so there's no difference between that in men and women, the prognosis in men and women. well, the higher the education, better. And in the event that the acceptance of the disease occurs, the adherence of treatment is formed, the implementation of medical procedures and prescriptions, acceptance of responsibility for the outcome of treatment, positive prognosis is formed. There are fifth, are there any dynamics in the process of rehabilitation process in the past and now? In the last decade, along with traditional methods of treatment, medication, exercise, physiotherapy, there's been an increase in physical methods of treatment. Drug therapy, wider use of anticoagulants, thrombolysis to an early stage of recovery, neurosurgical intervention, mechanotherapy, the use of robotics, biofeedback techniques, mirror therapy, computer programs for the restoration of motor functions. These are new methods help to reduce the severity of the consequences of disease, increase the prognosis of recovery. Rehabilitation treatment is a long process, and after an acute hospital, the patient it can be sent to a rehabilitation hospital, then the rehabilitation clinic, then to a district clinic. This is how a phased system of rehabilitation was conceived at the end of the 20th century by the Bechterev Institute overseeing this process. At the same time, we talk about the organization of the rehabilitation process and multidisciplinary teams in district clinics are insufficiently equipped. All this reduces the dynamics of recovery. And unfortunately, a lot of these district clinics have ceased to their existence. The sixth, how has the pandemic affected the rehabilitation process of patients? And in the pandemic context, the possibility of admission of patients in need of rehabilitation has decreased, which are forced to close due to the deterioration of the epidemiological situation, and the need for patient care in the polyclinic and multidisciplinary team is increasing. One of the complications of COVID-19 is an increase in blood clots, which leads to cardiovascular diseases, including strokes. In the context of a pandemic, the number of patients who have a stroke on the background of because of COVID has increased. There are no reliable statistics yet. The Dissertation research was completed in 2019. Therefore, at present, we have no carried out thorough analysis of the impact of the pandemic and comparison. And I would like to say my conclusion is that the dissertation of Ermakova, Nataliya Grigorievna, meets all the key requirements of the procedure of awarding academic degrees at St. Petersburg University, and the author of this dissertation deserves the third degree of Doctor of Psychological Sciences to be awarded to her in the specialism medical psychology 19.00.04. The plagiarism clause has not been violated. Thank you very much. The chairperson of the Dissertation Committee. Dear colleagues, do you have any desire to speak? So the curator. Are there any questions that be said by email? No. Okay. Before we conclude and vote, I would like to ask the members of the Dissertation Committee and the applicant, Are there any objections or questions as to the procedure of the conduct of this session, including the remote distance, remote mode communication? No objection, no objections. I'm very happy that no objections. Now we turn to the vote. We can meet and discuss for 5 minutes with behind closed doors. Do we need this break? No. And then I would like to put to the vote the resolution to award Nataliya Georgievna Ermakova an academic degree of Doctor of Psychological Sciences in the degree field 1904, medical psychology. I would like to remind you that the decision is positive if not fewer than 3 members of the Dissertation committee. Babkov Valentina Anatolievich, your opinion? I am in favor of the resolution to award the degree. Karpinsky Konstantin, I vote for the decision to award. Member of the committee, Svetlana Timofeyevna Potskova, I am voting for, but what I see as lacking the generalization. Karabakova and Abakova and is a member of SIVA. When when I wrote my review, I had a negative opinion, but when I heard Ms. Ermakova, I saw that she is abreast of all the issues in this area, and I'm satisfied. And I vote in favor, and I vote in favor as well. Buzova as the chairperson. To conclude, 6 members of the Dissertation committee voted in favor of the resolution to award the academic degree of Doctor of Psychological Sciences. So the decision to award the degree has been taken. The concluding remarks from the applicant. I would like to thank all those who has read my work, and this was a very productive discussion for me to develop my ideas. Thank you very much. The session is now closed. Thank you very much to all the members for participation. Thank you very much. All the best, colleagues. Thank you very much. Thank you.